So welcome all of you today to our webinar on health literacy and non-communicable disease. How can we do better? I'm Winnie from Galen Center for Health and Social Policy, and I will be your host today. This webinar is being recorded and will be available on our website. And I think most of our attendees are involved in health literacy and or NCDs. Hence, I encourage you to be a part of the discussion through raising your hand, using a chat box, or even a Q&A function. We will start with opening remarks by Mr. Ashrul Mahmud Khalid, founder and CEO of Galen Center, before hearing from our esteemed speakers. So without further ado, I will invite Ashrul to give a brief welcome remark.
Thank you, Winnie, and the emphasis there is on brief, right? So, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning, ladies and gentlemen and friends. Thank you for making the time today to participate in our webinar this morning, discussing non-communicable diseases and health literacy. This is the first in the series of webinars discussing this topic. My name is Ashrul Mahmud Khalid, head of the Galen Center for Health and Social Policy. I'm glad to see many who are participating in this morning's discussion are actually familiar faces in the NCD world, but for whom we have probably not physically met for over a year now. The COVID-19 crisis has dominated much of the public health landscape for 2020, if not our lives, and it looks like for 2021, the response, especially the ongoing vaccination effort by the Ministry of Health, Ministry of Science and Technology, and the components of the Jawatan Kuasa Khas Jaminan Akses Bekalan Vaccine, or JKJAV, will continue to draw a lot of attention, resources, and commitment. The Malaysian debut of SARS-CoV-2 in late January 2020 was viewed with much concern by both infectious diseases and later on non-communicable diseases experts. Those with comorbidities such as diabetes, chronic kidney disease, hypertension, and cancer had increased risk of developing severe complications, thereby potentially increasing mortality amongst those who were positive. The mortality amongst those positive in Malaysia has been so far mercifully lower in comparison to most countries around us and to the global situation. In one sense, thanks to the diligence and dedication of our healthcare workers, especially those in the public healthcare system, we have been able to avoid the scenario playing out in the US, UK, and even our neighbor, Indonesia. But the future of this epidemic, and indeed the global pandemic, is still uncertain. The fact is that a large proportion of the population living in NCDs in Malaysia are particularly vulnerable to developing complications due to COVID-19 infection. The National Health and Mobility Survey of 2019 findings released last year by MOH indicated that 1.7 million people actually live with 3 non-communicable diseases, and in this case, diabetes, hypertension, high cholesterol, and 3.4 million people live with 2 NCDs, that at least 50% of adults were either overweight or obese, and that 1 in 5 estimated to be living with diabetes. So more than 80% of COVID-19 fatalities involved individuals with at least 1 NCD, such as diabetes or CKD or chronic kidney disease. Early on, people struggled to understand the deluge of information. Grassroots initiatives produced, and the government produced numerous COVID-19 materials, translated them into multiple languages and disseminated them online. There was much about COVID-19, but the linkage highlighting the vulnerability due to NCDs was not as emphasized as much as it could have been. So what we do know is that many of our problems today, whether it is NCD related or adherence to COVID-19 SOPs, stem actually from poor health literacy. In general, health literacy in Malaysia was found to be low, where 30% of adults had at least one of the following: hard to manage medical issues, didn't understand well activities related to disease prevention, or comprehend health and healthy lifestyle practice promotions. So this is really, when you think about it, an opportunity for us to use during this time of crisis to actually increase the health literacy level among Malaysians by informing on both COVID-19 and non-communicable diseases with the aim of behavioral change. To that end, we are fortunate that we have, through a supporting grant from the World Health Organization, launched this project, which this webinar is part of, to look at ways for us to increase health literacy levels when informing on both COVID-19 and non-communicable diseases, targeting three populations, namely the elderly, foreign migrants, and the deaf community. So we've actually looked at selecting what kind of populations that we want to deal with, and we decided on these three populations. We have two speakers with us here at our webinar this morning who are well versed in diabetes and cancer to help us continue on this conversation and help shape some of the insights that we captured in the policy briefs and materials that we are helping to produce through this project. With that, I thank both Dr. Dina and Kenneth, who have, in Kenneth's case, struggled to get to hopefully his office or home or somewhere to be in front of the camera and to speak to you on this Saturday morning, to spend some time to have with us to discuss these issues. So I do wish you all a very good discussion ahead, and I look forward to hearing your thoughts on this issue. So I hand you back to my colleague, Ms. Winnie Ong. Go ahead, Winnie.
Thank you, Asro. Indeed, COVID-19 has opened up this opportunity to have a better conversation about NCDs, and it gives me great pleasure to introduce our first speaker, Associate Professor Dr. Dina binti Abdullah, who is a family medicine specialist at the University of Malaya, Department of Primary Care Medicine. She has been spearheading health literacy research in diabetes, primary care, and patient empowerment. So welcome, Dr. Dina, and I pass it to you.
Thank you very much, Winnie, for that kind introduction. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. Firstly, allow me to thank ASRO and the Gallen Center as the organizer of today's webinar, and also to thank Kenneth, my fellow speaker, who will help to fill any gaps in my knowledge of health literacy by sharing his experience on the ground with NCSM. Today, let me just share my slides. Do you think I can share my slide, Winnie? Okay. Can you see my slide?
Yes, doctor. Very clear.
Thank you. All right. So today, at the end of this very short talk, because like Aswa said, I would like to have a more active discussion. I hope to firstly introduce you to the concept of and definition of health literacy, why is it different from normal literacy, and how to highlight a few worrying findings from my own research about individuals' level of health literacy in the area of type 2 diabetes. Okay, so let's start with some figures. Okay, do you know that 1 in 3 of Malaysian adults has low or limited health literacy? So within me, Winnie, and Kenneth, there's already one of us with limited health literacy. And that doesn't sound right, because we are educated and all of us been to university and we held working blue-collar jobs. But that's the thing with health literacy. It is related to your literacy, which is your ability to read, write, and in some definitions, speak and understand information. But literacy is contextual. So health literacy is your literacy within the health environment, health area. So like me, so I always say this and I always get scolded about this, but that's true. My financial literacy is very bad. So, but I'm quite good with medical literacy. And that's normal. I think if we ask each and every one of us, there are certain areas in our life that our literacy is not so good. And when we talk about health literacy, that is what we talk about. Whether a person could be an active participant in the health environment to decide on to ensure that their health is good and they maintain their wellness. So the widely used and accepted definition for health literacy is one posed by the previously known as IOM in 2004, okay, which they say that the health literacy is the degree to which individuals have the capacity to obtain, okay, or access, process, or appraise and apply, and understand health information in order to make appropriate health decisions. So that's the aim behind health literacy, is to give patient more ability to make appropriate health decisions. Okay, so although the focus is on the individual, subsequent research showed that the environment also helps individual to perform these skills. Imagine a patient who is limited in her ability to access, understand, appraise, and apply information, but she goes to a center that helps to enhance her ability to do this. For example, this health center always presented very easy to understand information to their patients. Patients don't need to find their own information. Informations are readily available, easy to understand, and easy to apply. So in that sense, her own ability has not deterred her to be health literate and to be able to make appropriate health decisions. So if you see the seesaw, it's the interaction between the demands and expectation of a healthcare system and individuals' own ability. And I think this will be important when Kenneth talk about organizational literacy, health literacy, organizational approach to health literacy. So just to share some of my own research findings. So in 2016, what we did was we review the existing evidence or studies in Malaysia that's been done on health literacy. And what we found is that we were one of the earlier people to look at what the concept of health literacy. The earliest study was conducted in 1985, and this was done by, I think, a health information nurse or health education nurse, where she would like to know among the indigenous people, what were the perception or what do they think the cause of their disease were, and how does that influence the way they approach the disease and they manage the disease. And this was in 1985. But since then, there were several studies, not a lot. I managed to review a total of 31 studies, mostly done in general health literacy. But the next two areas that researchers commonly do research on were mental health literacy and medication literacy. Oral health literacy were also, there were also several studies on oral health literacy. And lately, the recent studies were on media and e-health literacy. And for non-communicable diseases, only one study measured the health literacy level in patients with type 2 diabetes in 2016. And at that point, they only found 14.2% of Malaysian patients with type 2 diabetes have adequate health literacy. So the level was even higher for limited health literacy. Another thing that we managed to do with the review was to summarize the tools that's been used in Malaysia. So one thing that we found when I did my study was that the tools is critically important, because if you use different tools, you will get different levels, and you will not be able to compare your performance within the community with another community. So in Malaysia itself, there's already 4 tools that's been validated and have a good validity and consistency to be used in our population. Okay, let's go now to non-communicable diseases. Okay, so what is non-communicable diseases? These are a group of diseases. For us, rakyat Malaysia, it's very important to know due to several reasons. But most of the time, when we talk about non-communicable diseases, we always think about these 3 important diseases. Okay, my patient will call it 3 serangkai. Okay, which are diabetes, hypertension, and high cholesterol. But these are not just, these 3 are not the only non-communicable diseases that are important in Malaysia. There are others, and including asthma, COPD, we have genital cancers, but also other chronic diseases like osteoarthritis. These are also non-communicable diseases that are important. But these 3, diabetes, hypertension, and high cholesterol, being focused more because they are actually risk factors for cardiovascular disease. And cardiovascular disease is the #1 cause of death in our country. And I think the statistic at the bottom there has been quoted by Astro at the beginning, so I will not repeat the figures. But just to say that if we just focus on these three things, we are already going to make a lot of difference in the lives of our rakyat. So in order to combat the epidemic of non-communicable diseases, the NHMS actually recommended these activities, okay? And if you read on, these are mainly recommendations for the individuals. So individuals were asked to control their blood pressure, okay, eat healthy diet, okay, maintain a healthy weight, okay, be active, stop smoking. But like Astro said, without health literacy, without adequate health literacy, it is almost a tall order to ask our rakyat to be able to do all this, or even our patients to do all this. So subsequently, my study focused on people with type 2 diabetes, and we did a survey using the HLS-Q47, which was one of the tools that's been validated in Malaysia. It's a bit lengthy because we got 47 items, but I know recently even in the NHMS they are using a shorter version, which I think has the same validity and consistency and quite good to use as well. So in my study, I found 65.2% of Malaysian patients with type 2 diabetes have limited health literacy. So more than a third of patients with type 2 diabetes could not, in their own, access, understand, appraise, and apply health information for them to make an adequate, appropriate health decision. And the tool that I use enabled me to look at the different domains because health literacy is mainly made up of the 4 activities: access, understand, appraise, and apply. I was able to see which of these domains that the patient struggled the most. And I found that it's the accessing. So this was quite a surprise because before I embarked on this study, I thought it would be the appraise or the apply. But because in their own, they could not access it, those information that they could access are actually given by their doctors that's already tailored for them to be able to understand properly, so that they can do it, they can use it in their daily lives. So we could have a little bit more discussion on that later. I invite people to ask me about that. So subsequently as well, I did a deep dive where I invited patients who did my survey for an interview, and I interviewed both the patients with adequate health literacy and then limited health literacy, and see how they navigate their way to get information to enable them to manage their disease. So what we found is that in Malaysia, there is 2 pathways. Okay. In other studies, either in the Europe or in the United States, most of the study will focus on patients' ability to pull their own information, meaning they have to be able to access it, understand it, appraise and apply it. They themselves go on the internet or the bookstore or looking for written materials to find out about their disease. So a lot of the tools are actually geared towards asking patients, were you able to do all this? But in Malaysia, we found that most of our patients got their information from other people pushing this information to them, telling them about diabetes, telling them about the medication that they're taking, telling them about how to manage it. And this part has not been fully explored by a lot of the tools that we use, because a lot of the tools did not ask, did someone tell you about this, and how did you appraise when information was told to you. So in that sense, maybe we need a relook at the tools that we've been using to make sure that the push way that patients are getting information will also factor in.
Dr. Dina, you have 2
And
minutes left.
and I got 2 more slides, so that's just nice. So at the end of my research, these were the 3 main things that I found. That limited literacy is a problem, and I would like to highlight that. It is not to stigmatize patients with type 2 diabetes, but to bring this problem forward so that we can develop policy and increase awareness, just like what we're doing today. And limited health literacy actually was found in vulnerable subgroups. So in my population, it was those that could not speak English very well. There was those with did not go for their diabetes management education, and those with lower social support. And this could be the target for intervention or to highlight that we need a multi-sector involvement. And health literacy experiences of multi-ethnic unique. So if you are trying to look into health literacy in other populations, such as the migrants or the differently able, that you need to understand how they themselves interact with health information. So that's at the end. These are the recommendations by NHMS on how we could deal with the limited health literacy level that we found, 1 in 3 in Malaysian population. So I think it echoes what I mentioned before and what I found from my study. All right, that's it. Thank you very much.
Thank you, Dr. Dina, for laying out the landscape for health literacy in Malaysia. And so as you said, a lot of countries, a lot of research has focused on, has actually expanded the awareness to include interactions with organizations as part of health literacy. Hence, we're really glad to have Mr. Kenneth Lau Kian Yong with us here today to share his experience. I think over 4 years of experience leading various initiatives under the National Cancer Society of Malaysia. So let's hear from Kenneth.
Thank you, Winnie. Let me just share my slide, then I would start. Okay. Right, can you guys see the slide?
Yes, I think you have to go full screen. There we go.
Right, bright yellow to add some.
Very vibrant.
Right. So it's in bright yellows to add some vibrance, yes, to the conversation. So I would say almost good afternoon, but good mornings to all. And thank you so much, Galen, Mr. Azrul and Vinny for inviting me over to share some humble experience in terms of NCSM. And thank you, Dr. Anina, so much for setting the ground and talking about how is the current situations of health literacy happenings in Malaysia. And precisely, there's one thing Dr. Anina has mentioned very important. It's about setting the environment. I mean, through research, we can identify there is a lacking of health literacy. There is a gap of health literacies to be addressed. But however, when we look at the environment, how does we apply or translate this finding and really go to the ground and apply some of the things that into the groundwork? So I'm here to share some of the initiatives that we took as NCSMs that we are actually, I would say, we're consciously aware that this is some part of the works that we are doing on health literacy. So I'm Kenneth from the Health Education's Literacy, Promotions and Policy Department. As you can see, it might sound very, a lot of things there is like 4 different components. We actually consciously rename it into this is because we do realize that there is a very distinct difference between all 4 elements, but of course they are not working in silo, but we are just trying to emphasize that when we are talking about health concept, it's actually slightly bigger than we thought. Yep. So today I'm going to talk about a couple of initiatives and then give you some definitions in terms of how difference between individual level and organizational level and what do we expect coming out from this differentiation. So what we do basically is bridging the barriers and building the networks between health educations, health literacy, promotions, and even up to policy. Right. So I'm going to start with personal health literacy. As Dr. Adina mentions, health literacy is basically something beyond literacy, something's beyond the readability, and then also how you understanding just the sentences. I would just want to say that health literacy could be just as simple apply as when you are ordering menu. When you are choosing between something healthier like a chicken salad perhaps compared to fried chickens with fries. So at that point of time, you are some sort of using your own health literacy skills in deciding which is a better choice. Yeah, we all know that, but do we want to make a better choice? It comes back to us. So when we talk about personal health literacy, it's basically about finding, understanding, and using the information, including services as well, and in order to make a health decision. But how does this difference compare to organizational? So when we are quoting one of the health initiative 2030 by Healthy People Movement of the CDC, US government, when we talk about organizational level of health literacy, it's mentioning how does organizations like how do we become an enabler to people when they comes to applying this sort of skills or this sort of knowledge. So what do we identify? It's actually sort of like a 3A strategies. So this is not quoting on any papers. So this is merely something that we are deciding, and this is how we steer our directions when it comes to planning about the things that we do, how NCSM's strategies will have influence. 3 things I would like to highlight here is number 1, where we talk about acknowledgement. This is very similar concepts when it comes to awareness. You want people to be aware, to acknowledge there is a problem and it's related to health and related to literacy, and how would you do that? Second, it's about effects. So this is talking about how does this information actually affecting their daily life? Does it really matter for them? Whether they are knowing this is important, this is not, how does this going to impact their daily life? And third is talking about providing access, because no point you are actually talking about a lot of things and then you're telling them these are the things that you should do, but in other words, that you are not empowering them, you are not enable them to use that sort of knowledge they will have gained. So in the coming 3 slides, I'm going to emphasize on all these 3. So first, we're going to talk about enabling people to find, so which is some things that align with these 3 ability. So first of all, we go to the community. So when it comes to the community, it's not merely providing just a screening itself, not just doing like, you know, one-off screenings and come to you and yes, nothing has happened. And then in 30 years time, we might come back, we might not, because it depends on the resources and time. But in terms of bridging this barrier would be, we are providing a one-chain solutions when we do screening. And if there is any abnormalities detected, we actually rose the individuals up to diagnosis, even directing them to treatment, and also the survivorships component, which I'm going to share later in the slides as well. But basically, we are consciously aware that you are not merely doing a screening, you are empowering them to know that why is it important, and if it's so, something has happened, something's really not nice has happened, when it comes back with a positive result, what should this person do when we talk about health literacy? Because in order to tell them like you need to find more info Google, it would actually add on another barrier of them. So in order to navigate them through the system, which is sometimes could be very complex when we talk about people who's not working in a health sector. So this is how we actually navigate people through, starting from the screening and even up to the survivorship. Oh, I will have to put this in context when we talk about cancer care continuum. Is screening, diagnosis, and then we'll say treatment and also survivorship. So this is the chain, but of course, before that will be prevention. Secondly, we put in places where you can see. So a lot of times when we talk about health messages, it's always about reinforcement. We all know that some of the health information actually could repeatedly over and over again have been emphasizing. But the reason being why is because, yes, we have not achieved 100% of awareness, we have not achieved 100% of health literacy, and this is why reinforcement of messages needed. However, we are considering the fact that where do people see these messages? So sometimes people don't always go to a health related institutions to get sort of health information. There is all sorts of creative way for you to disseminate this kind of information where people are going there with a ready to learn. So for example, education institution would be a very good target if you are talking about universities going adolescents and young adults. But when we talk about religious institutions, that would be another element that we can put in when we talk about putting places that people go. Thirdly would be this, I would say, send it to your phone. So as COVID-19 has opened up the technology enhanced platform for everyone, I would say that now sort of like technology literacy has been improved because of COVID. People are more aware about Facebook Live. People are more aware about handphone, getting informations, Googling, Zoom, all sorts of social media platform. But this is how we are leveraging on this opportunity by using and applying WhatsApp messages and also social media feed, because we know that now people is no longer very new to social media, but in fact, people are trying to look for something new. So this is the first component where we talk about enabling people to find. Second, we want to enable people to understand. So the first part where we talk about understandability, we're saying about the materials that we develop. So at this point, NCSM actually consciously aware, and we do pilot testings of our materials. So we do sense to the potential user, for example, if the booklet was meant for the community, so we will sense to the community people to proofread, to go through and understand whether the language is appropriate, whether the structure is okay, whether the flow is easy to follow. And you will see that skills-based workshop has been applied as well. But I would like to highlight another thing is about Malaysian. We are a very beautiful country with diversities of culture, but it could be a problem when it comes to health literacy is because whatever efforts we are trying to do, perhaps we have to do slightly more. So slightly more in terms of multiple languages, addressing this diversity itself, because we do know that people who actually speak BM very fluently might not necessarily speak the other few languages are very fluent. So we are talking about tackling the informations in the mother tongue manner, where we consciously doing topics. When we are running workshops, when we are running talks, we are now planning all workshops in 3 languages. So just to make sure that the material that we have identified, there is the needs of these materials to be developed, and this would reach all across Malaysian. So when we talk about Malaysians, we wouldn't want to talk about the language barrier itself, but we want to tackle it as a whole. So this is how we be cautiously doing the materials in 3 languages, and we are doing the sessions in 3 languages as well. So thirdly, we're talking about actionable messages. One of the things Dr. Dina has mentioned is when we encourage people to do something, people have to first understand and people have to plan. So this is how we enable people to understand and use where we talk about call to actions. So basically call to actions is a very simple concept where you give directive, instructive recommendations so that people can follow if people would have understand and people would like to do further. So this is how we are enabling people to start understand and start to apply and get them to use the information that we have learned rather than just being aware that this information has been provided. And this would actually link to the third point that I'm going to talk about, enabling to use. So in terms of barriers that we have identified, there's couples of things that stopping people of accessing to services, regardless of which continuums we're talking about, regarding which components we are talking about cancer care continuum. One of it is actually geographical difficulty. So NCSM has been setting up a children's home for almost 20 years, where we actually provide free accommodations for cancer children who is getting treatment at HKL, because a lot of the treatment of PITS on-call are still remain very much in the centers of KL. So how do we remove the barriers by providing free accommodations? It would actually save up a lot of cost of them. And this year, despite COVID has hit us really hard, I mean, thanks to a lot of generosities of supports from various people, we actually managed to put up the adult home of hope as well. So now we have been extending our services to even providing free accommodations for adult patients, because sometimes we do see that some of the patients, when they comes about age of 17, when they are transitions to 18 years old, they actually has been moved from the PITS on-call to actually the adult on-calls. Then they would have not be able to enjoy the privilege, I would say here. So secondly, we talk about financial difficulty. So as a lot of people heard about cancer, the first thing we strike is a very expensive and deadly disease. But expensive will have come first, because they will say that money would be issues for cancer treatment. And this is how we're trying to reduce the burdens amongst the people by putting up some sort of programs like patient assistance program, where we work with our partners trying to reduce the cost of some of the diagnosis or even screening courses, trying to bear the very minimum. But in fact, we also try to assist financials for treatment as well with some of the pharmaceuticals company. Yeah. Secondly, we talk about confidential second opinion, because we are trying to set up an independent body where we gather experts to provide second opinions in a PAC format. So there would be a private and confidential service, but what we're trying to do is we want to convince the people to look on to conventions medicine by encouraging people to take on the recommended oncology treatment, so that you would reduce people from dropping off the treatment as well. Because one of the problems we have identified is also, nationally identified, would be the late diagnosis as well as people dropping off from the treatment of cancer itself. Third and last is about psychosocial support. So we have mentioned, yes, Winnie, am I about time?
It's 2 minutes.
Still
2 minutes.
a few minutes to go.
2 minutes, yeah.
Right, I will wrap it up in 2 minutes. Yes, sure. So in terms of psychosocial supports, we do understand that cancer itself is not only affecting the patients physically in terms of the treatment, in terms of the disease itself, but also the other components like the social well-being, as well as the psycho behavior or emotional health when we talk about. So this is where NCSMs come into the path, that we are, at one hand, we're telling people that these are the very important components and elements to address. On the other hand, we ourselves provide the services so that we would bridge the needs to the supply itself. So this is where we provide free psychological interventions, including counseling, including clinical psychologist sessions, as well as play therapies, and also free dietary consultations for cancer patients, as well as their caregiver. Because we do understand cancer, it's not an individual disease. Sometimes it could impact the entire family. So this is how we have seen that how NCSM would actually package, or I would say direct ourselves, that trying to give a very holistic approach covering different elements. So I would say this is actually the last slides of my presentations, but I would just put it up back again to conclude here. When we talk about abilities, so this is how NCSM seeing ourselves playing a role, become an enabler to make sure that people would find the ability and to use these abilities accessing the health information and services, right? So with that, I will just put up a nice picture of thank you. And I believe that we all can give back to the community in a certain way. And I hope that if you find a way that you will work with NCSM, feel free to contact me as well. Very lovely to work with everyone in the field. Thank you.
Thank you so much, Kenneth, and thank you, Dr. Dina. So I just want to do a kind of reflection for a layperson to start with. So if we, basically, both of you have brought up an important point for Dr. Dina to start with is health literacy is this balance between skills and expectations and the balance between expectations, demand, and skills that a patient has. And what Kenneth has told us is there are kind of multiple levels where we need to enable the person to make the best choices. So if we talk about NCDs, in general, if it's related to lifestyle factors, a person starts, is healthy to begin with, and then they accumulate risk factors as they age, and then it takes decades until you get diagnosed, and then you enter the health service where another set of skills will then be needed for you to live well until then. So this is, I think, something that may not be well acknowledged, or perhaps we are starting to catch up with the idea as NCDs is becoming a bigger problem in our society. And so let me start with a question from one of our participants. How would we, be able to, so it's very interesting as well. I think what Dr. Dina said, most of the time we actually push information to our Malaysian patients and people. What is something that we can do to increase the pull factor?
Okay, thank you. So I think what Ken's presentation has illustrated the pull factor very well. So I think what NCSM has done very well is that they understand their clients. They understand the living situation and the whole way that patient with cancer access information, and they then assist this patient by giving them information that they need. But if you think about it, during my research as well, what happened is that this information comes from the provider, meaning NCSM, or if you think in the context of a healthcare, let's say a doctor. It might be important information that patient needs to know, but it might not be the only information that they want to know. So I think that is the thing about when you're pushing information. But in Malaysia, that's why my conclusion was that the cultural aspect, okay, we are still a very paternalistic community. The way that information was relayed to us traditionally is from word of mouth. So it's always, if you think about our granddads and the people in the kampong, that's how information were transmitted. So they don't have Twitter, they don't have WhatsApp at that time. So information were given through the word of mouth, and usually from the more senior people to the younger people. So this has been, it still is in our community. So what I found is that influence of friends, influence of colleagues, influence of people in the community that has a higher social standing, they still have a very important role in giving out information. And this is what we found with misinformation as well. So if a doctor started to give misinformation, pushing information to people, these are easily absorbed by people and they easily take it on. And I think from Fredo's question as well, do they appraise it? Of course, they don't appraise it. So they don't have the skill to appraise. So they just accept those information as is. So there's one very interesting quote from one patient. So I asked him, so you got this information online, so how do you know whether this is the truth? He said, well, these people don't give evidence, but my doctor don't give evidence either. I don't discuss evidence with my doctors either. So neither of them give me evidence. I don't really know which one I should trust. So I think in the way that doctors communicate with people, we need to improve that as well. And I think with the work done in risk communication, evidence-based medicine, shared decision making, we are trying to get there in doctors' point of view. So doctors need to be trained, but patients also need to be more curious in asking, oh, is this true? And I think we're doing that a little bit. Thanks.
That's a very good point. Basically, we have a very good national survey that has given us this very rigorous data about who has particularly limited health literacy or who has very excellent health literacy. So I'm imagining that at a state or district level, we can kind of get a picture of what the population is like or what their needs are. So knowing that there are these cultural factors and there are social determinants that means that certain subgroups will have limited health literacy, how would a bottom-up approach look like, perhaps at a district or state level, and who would be the actors that should be involved? Maybe I could ask Kenneth.
Yes, sure. Okay. So first of all, I would say that how does a bottom-up approach could be possible? I would say that thanks to researchers like Dr. Dina would have actually set the ground of how does the data has come across, like how is the module, how is the framework being identified, and then we can identify what are the shortcomings or also challenges at the ground. But when we talk about workings from the bottom-up approach, the most significant, I think, is you have to work with the communities itself. So meaning to say you have to reach out to the community's leaders, and then you have to speak to them, have a conversations with them, and then identify what is the most burning issues with them. Because it could be not because they are not aware about the health informations or the health decisions to be made, but what are the choices they have. So one of the examples would be a free mammogram programs that NCSM has been running for 3 years, and this is the 4th phase. So what we do is we are actually gathering community leaders to identify women who is within the criteria for screening and has not done screenings before. But of course, this is something only when there is a privilege of sponsors. But this is something we see by enabling them, providing them the access itself would have actually done better compared to just giving them an information and tell them like, let's get your screening done. Because it's merely telling them a message itself without providing access or without bridging them to the services. That is the difficult part. But how do we enable that is actually working with the community leaders, because it's impossible for you to go to a kampong, let's say, and then you just convince them like, come, I have something free for you. You know, now people is being very skeptical despite it's free stuff, despite it's a health related free items, but why would I do that? And how would I be convinced? So in terms of the convincing part, we are leaving it to the community leaders, but what we do is coordination and also the logistic arrangement. So we even give up like allowances, food allowances, you know, just to provide F&B, so that some sort of them, they don't have to worry about these tiny elements, and even provide transportations to shift them from their kampong to the respective institutions to screen. So for an example, if they are in the Pahang, they don't have to travel to KL or NCSMs to do the screening, but we are liaising with one of the hospitals that are local, and then we are actually matching the services with them. So this is how we are building the networks with various hospitals within Semenanjung at the moment. And then we have been working with about more than 10 hospitals across, about 14 hospitals across these 10 states. We are unable to do it in East Malaysia's reason being because of the medical resources is very limited. And traveling a person from a very inner of Sabah to Kota Kinabalu itself, it's very difficult. So we has not successfully expanded to East Malaysia at the moment, but we has been running the model very successfully in East Malaysia. Yep.
So it's knowing the gaps and then working with the infrastructure, working with the community to consciously bridge those gaps and empowering the people who you've identified to be quite disadvantaged to actually benefit from those interventions. Dr. Dina, do you have anything to add?
Yeah, I would like to two things actually. Number one is that in terms of NCD, I think we need to do some reflection and ask ourselves, have we done enough for our community? And I think here I would like to highlight the activities that we've done with COVID-19. I think it would be devastating if I go up to a patient with type 2 diabetes who had type 2 diabetes for 10 years and ask her about type 2 diabetes, and she could answer, but she could answer everything about COVID-19 to the structure of the virus. So I think that's very, very, that should not happen. So I think with COVID-19, we've done a lot and we've learned a lot. And I think we should try and translate that to NCDs now. Because with COVID-19, the whole sector is involved. You know, from you know, National Guards and you know, all the legal people. You know, we are in darurat because of COVID-19, but the number of people dying from NCDs are larger. And you know, if 5 people get diabetes and we shut the economy down, and then people will give attention to diabetes, we can't do that. So, but we have to learn from COVID-19 and try and do the same thing for people with NCDs. And I think what Kenneth is saying is absolutely, and one of the things that I found in my study as well is that social support makes a difference. So if you yourself has low health literacy, but your social support has really good health literacy, they enhance your level of health literacy. So the people that you're trying to target might be difficult people to target, but the people around them might be easier. They might be the more savvy one, they might be the one online, you know, they might be the one that can understand this information better. So it will improve the community health literacy, you will improve the people with lower health literacy. Because targeting the people with lower health literacy sometimes is very difficult because they, throughout their life, they have poor education, they could not, you know, they are disadvantaged in their life. So targeting difficult people, like Kenneth said, you have to know where your winning balls are. You know, you don't go to the game that you're going to lose, to the game that you're going to win. And by in health literacy, there's an advantage because if you win with the people that's easy to improve their health literacy, you essentially will be able to improve the whole community's health literacy.
I totally concur with you. So basically for COVID-19, we are immersed in it. Our local grocery shops, our restaurants, everyone is involved in it. And therefore there's this attention, there's an urgency, and we have learned so much about it in a short period of time. We learned together with our doctors and our government, and every day there is news about it. So it has disproportionately, I think, received so much more attention compared to NCDs, despite the burden of NCDs being so much more greater. It is the top killer, you know, in our country. And I think you're right, Dr. Dina. We may tend to actually target our interventions at people who are already health literate or who already have the necessary support. If we don't go and consciously look for people who are in very disadvantaged situations, or like Kenneth said, maybe in kampongs, or maybe even in urban areas, there are definitely pockets of where we have this disadvantage, and we may not address it with our current general health education campaigns. Yes, so I would like to pose a question from our participant. Basically, how much resources do we have in the Ministry of Health for health education? So I guess that could be answered by Dr. Faisal. What proportion of the MOH budget is available for health education? Would you be able to answer that?
Thank you, Winnie. Just put can you hear me, Winnie?
Yes, I can hear you. This is Prof. Aisha's question. Are you there, Dr. Faisal? Yeah. We can't hear you yet.
Perhaps while we're waiting for Dr. Faisal to connect to the audio. So Dr. Faisal will have mentioned here one thing about communications, and I think I would like to put my reflections on that. So when we talk about evidence-based practice, we have been pushing it amongst all the healthcare professionals, even all the doctors. We have been telling them evidence-based medicine, evidence-based medicine. But when it comes to health communication, it's a bit different, because we speak the science, but we might not necessarily speak the layman term when we talk about communicating to the community itself. So that would be another challenge, and also barriers in giving out the information. For us, maybe constipation is a very common term, but constipation itself for a layman, it would be like, what is that? Yeah. So sometimes things that we didn't put into practice, or we didn't put into the context of understanding how they see these messages. And sometimes as a practitioner, I mean, regardless, you are in public health, you are in the medical health. So sometimes you delve it too much with your own, and we forgot to put a pause and think like, who are we talking to, and what are the channels that we are using to talk to them? So that would be a very important indicators on how you tailor your interventions, and then also the messaging, because you can't do health literacy without giving information, without providing health information. So it's also sort of like merging it with health education. And when you talk about health education, communication is the key. How do you communicate a health message would be very different on how you talk in a daily life. Yeah, so I would just want to highlight that Dr. Faisal have mentioned a very important point, which is health communication could be something that we need to start look at among the practitioners. Yep.
How can we measure health communication that is targeted at a population that perhaps healthcare or even health promotion bodies, they did not previously, they may not be familiar with working with people who don't access healthcare, who never reach healthcare, right? So how do we, are there any tools that organizations or health systems can use to improve that communication?
That will be a very technical questions that I hope, yeah, Dr. Adina might
Adina
have.
maybe.
From my take, it's but from my take is we could actually match it back to the health literacy, because when we talk about communication, is you just want to get the message across. So how do you measure whether the message get across? Is people do understand what you're talking about. So it's sort of like coming back to the ideas of health literacy. So that's my opinion. Yes, over to you, Dr. Adina.
So okay, so like Kenneth said, the title of his role is very long. Each thing functions differently. So health communication actually is in the realm of health promotion. This is looking at techniques, and a lot of people are doing this already. So there are like techniques on how to communicate, how to frame information that you give to a community and your patients. So this is a separate science to me personally. I think it's a separate science to health literacy, because health literacy is about the person itself, and communication usually comes from the organization and in the interaction. So I'm not so privy to the science of communication, but I'm sure there are tools around that could measure this. So, for example, people can measure like from your pamphlets, if you're doing pamphlets, like the level of readability at what level. So I'm sure Kenneth does that for his education material. So I think he mentioned it just now in his presentation too. It's about framing. How would you do it? And like Kenneth said, the way he does it is by giving actionable words. Okay, you can do this. This is what's going to happen when you do this. And then there's a few other techniques that's around that I'm not so aware of.
Multifaceted. Yeah. I just wanted to kind of share this slide just to highlight that health education is part of health literacy, as Dr. Dina is saying. It's not the whole of it, and there are so many other aspects of interventions that we can look at. So patient activation, for example, community action, self-management, family carers, and this is kind of a framework that I found really useful to understand this concept. And yeah, so health education is not the only thing that Ministry of Health has to target health literacy. Would I be able to call on Dr. Faisal to give maybe some remarks about this?
Thank you. Can you hear me, Winnie?
I can hear you clearly.
All right. Do apologize. My line's not that well. Thank you very much to Galen. Thank you very much, Dina and Kenneth. So I don't have answers. The question that I heard for is there enough resources? I think the question is not just enough resources. My question is, do we still think we are doing this correctly? Patient education, health literacy. I think we are not. I think the main reason is that we are learning from, we learn from our seniors, and what our seniors are doing may not necessarily be the best thing. And we are creatures of habit, and we develop habits, and we're talking about healthcare providers here, right? The healthcare providers perspective, and we learn from our colleagues as well. So what I would like to say, I don't have answers, but I do know what we're doing now is not right, even if we throw more money at it. We need to. So one of the things that I put in the question was, we are pushing information, we as healthcare providers, but the purveyors of unhealthy products or dubious products are also pushing information. So, and the friends and family members, although their intention may be good, but information may not be accurate, they are pushing information. So my question is, why are our patients more prone to believe what is being pushed, not by us, but by other people? Because both are push, they're not pull. And I don't think we have enough information to answer that. And I think it's very crucial for us to really understand that, so that we can then design an appropriate interventions. My theory or my guess is that what is being pushed by the others, not healthcare providers, by people familiar. So familiarity is something important. It's closer to their belief systems. It appeals to their heart, to their emotions. That's how sellers get to us, right? Closing the deal. So perhaps then healthcare providers need to look at closing the deal rather than evidence-based. I find it interesting as well. Dina mentioned about, we as healthcare providers also don't tell patients about evidence-based, right? We just tell it as it is, and that's correct. I never thought about that way. So for me, definitely need more people like Dina to look at that kind of research, and depending on the listeners here, you don't have to be medically trained. This is about behaviors. This is where we need people who does sociology, anthropology, the soft science, not the hard science of medicine, to to look into that research to understand behaviors. There are many aspects, and we're talking about health literacy today. I'll stop there. Thank you very much, Winnie, for the opportunity. Back to you.
Some really good points, Dr. Faisal. And I think from the presentations that we heard from today, we know that we're kind of at a critical juncture right now where there is this rapid learning about COVID-19 that seems to have taken a lot of people's attention and headspace, and policymakers' attention as well. Whereas NCD is kind of this always in the background, not the priority of a lot of people. But I think we heard some very actionable messages today from both Dr. Dina and Kenneth, which is that we need to intervene kind of at a community level and also at multiple levels of health literacy. So it is not just an aspect of providing information, it is also how do you use it and how do you appraise it, and then linking them to the health services, for example, the screening, for example, the healthcare that's available to actually enable them to successfully bridge the gap between the skill and the demand that's made of them. So I would like to wrap up. I think I have one more. Yes, so we have a question from Dr. Lim, who I think is part of the Better Health Program, another community-based NCD program that is running in Malaysia at the moment. She's asking, when we communicate about evidence-based medicine in layman terms, how important is it to establish trust and relationship building? And how do we do that if in a clinic you kind of have very little time? Should we do it at an organizational level? Do you have any ideas, our speakers?
Can I start? Can I?
Yes. Okay,
Yeah.
go ahead.
Yeah. Thank you, Faisal, just now to tell us about the situation currently. And but I agree with Prof. Aisha in terms of her comment there. It's good to collaborate so that we can look at the areas that it's more critical to the health system that we can have more evidence for. And like Prof. Aisha said, a certain institution has other people that we can work with, like the educational experts, and they can bring in their theories, and even the sales and business department, they can bring in their marketing theories. So there's a lot of people that we can collaborate with to help push the right information to the community. Okay, Dr. Lim, in terms of communicating EBM in layman's terms, I totally agree. And one of the things that I found in my study as well is that trust is a very important point. So like Faisal said, why do they believe their family members more than the health system? It's because they trust these people more. And the trust for the healthcare is still there, alhamdulillah. Fortunately for our country, certain countries it's not so true, but in our country the trust is still there. And one of the major source of information is still the healthcare professionals. But like Faisal said, we probably need to do a little bit more with our healthcare professional. It's very easy techniques. We can do a simple thing called teach back, where we just ask patients to just repeat back what we've told them to see whether they understand what we already tell them. We need to just bring in a little bit about science and what's going on with them. And this is the part that Faisal was saying, that we need a little bit more evidence in this area to say that how much do patients want to learn about their disease? How much does learning about their disease help them to manage their disease? Well, does Kenneth need to tell them everything about breast cancer, from the actual cell that's been mutated to the gene changes, or just to say that it's breast cancer alarm in the breast? Is it enough? So all this has not, the research is still very scarce. We still need to go do a deep dive and find out about all this. And communication, health communication, we also highlighted to be another important area to look at.
Thank you for that, Dr. Dina. I would like to ask Kenneth to maybe give some closing remarks, or where you think you would like to move forward as an organization from a health literacy perspective.
So I think, of course, so I think Dr. Faisal will have actually drawn up the problems itself, where a lot of us actually is working on your own, and then you have, this is how we've been quoting, like everyone is working in silo, and for past 30 years, people is still in their own silo. and that has not been collaborating much is because people believe that what they are practicing or what they are doing could be the best interventions, but perhaps it's time for us to look at multiple collaborations with different partners as well, like Prof. Aisha mentions with the academics, when we talk about the learning theories, the behavioral change model that we can apply in terms of this health intervention. So what Dr. Dina has mentioned, I would say she will have answered all this herself, and Dr. Lim will have put up the point that when we talk about evidence-based medicine, but what I could see is a lacking of is health communications between the practitioners, where in the current medical educations module, I don't think there is much of emphasis when we talk about communicating diseases or communicating medical terms to laymen. So that could be some things would be added value if they could revisit the curriculums itself, perhaps, so that it would actually tackle another issues at the very beginning, where during their practice or during their training itself, they have been consciously built into their mind that, you know, when you are talking about science, when you're talking about medicine, it's not only showing or telling the patients like, I'm giving you drug A, please take, and then by few days later, you'll be all right. But it's actually a wider scope, and now people are actually smarter. So when we put smarter, it's people know to ask a lot of questions. People know questions to raise. People know uncertainty to ask the doctors, and doctor has to be more prepared in these terms. So I think this is some things that we could look at itself. Yeah. So I would say in terms of health literacy, when we talk about organizational, we could do the groundwork, but we will need other partners like I would say MMA to constantly train the medical doctors up to the par where we're shifting. Now it's no longer talking about medicines, but talking about health communications within the medicine field. And we also work with academicians like Prof. talking about what apply. And of course, we'll work with Dr. Faisals at the ministry level, look from the top itself. So that would be my point on this one. Yep, thank you.
Health
Dr.
literacy.
Adina raised her
Yes,
hand.
Dina.
Maybe she would like to add on some of the point.
Yeah, Dr. Dina.
Sorry, that's the right time to add on to Kenneth's point. A lot of people think communicating science is difficult, and a lot of people think that our population could not understand it. But that's exactly what we're doing with vaccine, isn't it, really? That's exactly what you're doing with vaccine. You're saying that this is 5% effective. What does that effective mean? How do you know it's effective? So you tell them about RCTs, you tell them you tested that in that, how many people. So we are starting to do this. I mean, COVID has been pushing us all ways, and this is one of the important ways that it's been doing that. So keep the ball rolling. Go on to NCDs. Go on to tell about, you know, efficacy of cancer treatment, efficacy of diabetes treatment. We can do it, and the government has been doing a good job. So they just need to expand it to NCDs. Thank you.
Thank you, Dr. Dina. So a health literacy in all approach, you know, to help us drive towards the better outcomes that we want to see for NCDs. It was such a pleasure to hear from our two experts here and the rest of our attendees. I do hope that the webinar will be of benefit. I think we will be preparing a policy brief after this, and to get the general public to talk more about health literacy, as less of an academic concept, as something that is empowering to them and just a daily tool that they need to navigate modern life and health and wellness. So I thank you all for joining us today. We are over time. So thank you so much for bringing your experience and expertise to the table. Thank you. That's all from me. Have a really great weekend ahead, everybody.
Thank you very much, everyone. Thanks, Kenneth. Thanks, Winnie. Thanks, Asrul, and the rest. Bye.
Thank you. So I would say that when you're ordering food for lunch later, perhaps health literacy would kick in slightly.
Already starting to
weekend,
use
everyone.
the principles. Thank you, Kenneth. Thank you, Dr. Dina.